All right, now we're live. Wonderful. Okay, you guys. So, as everybody is jumping on live and as you guys are listening to the recording from the podcast, thank you again for being here. I'm Janae Peterson. I'm your host here on the I Believe podcast. And we are thrilled to have Dr. Orloff with us from Philadelphia. She is so kind for taking the time. So, before we jump into her presentation and hopefully can answer some questions on liver directed therapies, let me just make sure to run through some announcements. So, first off, thank you guys for anyone who participated in Giving Tuesday with us. If you have a fundraiser that's still going, please make sure to go through and end your fundraiser so that we can total all of our donations and just get that announcement out there. Next up would be that we have Steps for Sight registration. That's coming soon, later at the end of this month. So keep an eye out for that. Make sure you're on the email list if you're not already, and make sure to get registered for Steps for Sight when we are ready to go for January. More announcements from 2022 steps are coming, so just make sure to keep an eye out for that as well. And I just want to make a plug for something that I posted earlier today. And I'm just going to kind of like lead it with this, but we really have to advocate for ourselves. And that's hard, right? Like we have a rare cancer, it's already hard enough. So like, then you throw in this idea of like, we have to self-advocate, and we really have to kind of be this grassroots movement of people who make sure that pharma companies and researchers and doctors like that, they know we are important and we matter and we want research happening. We want an impact made in the world of ocular melanoma. We have amazing doctors like Dr. Orloff, Dr. Sato, so many oncologists who work so hard to take care of their patients and who research. And it's exhausting for us as patients to deal with this diagnosis. But if or whenever you have the chance to just talk about ocular melanoma on social media in any capacity, please just remember to share and make a fundraiser for a Cure in Sight to help our organization to continue to help patients and to be able to aid patients who need it, to travel if they need treatment somewhere else, to give resources to all of you guys like this podcast, and to continue to locate highly relevant research that we can be a part of as an organization. So if you have connections to anyone who has a business at the end of the year that maybe could use tax deductible donations, we would love for you to make a plug for us and just ask if they are willing to do that. Make a donation to a Cure in Sight for the end of the year. If you have an employer and they are willing to double a donation to a nonprofit, then ask if they will consider doing that for a Cure in Sight. And same goes for anyone with your family and your friends and your community. But to make it easy, if you head to the pin post here on Facebook or on Instagram, you'll find a shareable post labeled "All I Want for Christmas is a Cure." And so we just ask that you guys share that and just ask your community to donate even just $5 this month. All of us, we want this. We want a cure, Omis. So let's just take a deep breath and let's recognize that we are the ones who can share about this and we have the power to make a big impact. And let's just keep it front and center in people's minds, even with the busyness of everything going on. So that's all I'm going to say about that. I'm actually going to go ahead and welcome Dr. Orloff. She is an associate professor of medicine and a medical oncologist at Thomas Jefferson University Hospital and Sidney Kimmel Cancer Center in Philadelphia, Pennsylvania. So Dr. Orloff, thank you so much for being here.
All right, thanks, Danae. And hi, everyone. I can't see you all, but hopefully you're out there listening. And I think this gets recorded to be able to be watched later, if I'm not mistaken, Danae. So hopefully that's the case. So what I thought we would do today is talk about liver-directed therapies. This is a type of treatment that is not a treatment option for all cancers, and it is something that is unique to uveal melanoma. And I'd like to just go through a few slides just to kind of set the stage, and then we'll open it up for more of a discussion. So I'm going to go ahead and share my screen. Oh, hold on. I got to swap that. All right. How does this look, Danae? Okay. Can't see you because I'm in screen share. So I just want to make sure it looks okay.
So I can see it. It looks good. And
Okay.
then I am going to see if I can do anything. And you know what? Actually, if you take your camera, bottom line of the settings, there's going to be a spot that says cam in the Riverside screen. And if you take your camera off, and I'm going to take mine off, I believe it will make this bigger for people.
Okay. I think my cam, all right, my cam's off.
Okay, and then go back to your slides.
Back to my slides.
Perfect. All right, I'm just looking on Facebook to see if we see everything better.
Swap.
All right. I can see it.
Good.
Yeah, I think that's better. I took my camera off, and since I'm no longer with the camera, I think that will help it
Okay.
show up bigger. So it looks good.
Perfect. Okay. So, like I said, today we will be talking about liver-directed treatments for metastatic uveal melanoma. All right. So, just a brief overview of what we'll chat about, the rationale for liver-directed therapy, because I think sometimes that's not always super clear. The types of liver-directed therapy that are out there that we consider kind of standard of care that you could really get, off a clinical trial, all things that we certainly offer here at Jefferson. Some of the types of liver-directed therapy that are still considered investigational. And then, I think who is a candidate, actually, I moved that up. We're going to kind of talk early about who is a candidate for liver-directed therapy, and then some limitations and considerations. So, why liver-directed therapy for liver mets and uveal? As many of you know, about 90+% of metastatic uveal melanoma patients will have liver metastasis at some point in their disease. Often it is the first site of metastasis. That's why, we very much follow patients looking at their liver first. We say kind of liver kind of on a scale of 1 to 10. We care about the liver kind of 1 through 9, and then, lung and other things, kind of down in the list. So, frequent imaging of the liver, very important. And really, even if there is extrahepatic disease, the liver mets are often the source of life-limiting disease. And so that's just kind of the background. And then the rationale for the approach more kind of scientifically is that the liver is an interesting place in that it has dual blood supply. It gets about 75% of its blood flow from the portal vein and about a quarter of it from the hepatic artery. So it is a little bit redundant, but actually liver tumors obtain the majority of their blood supply from the hepatic artery. So you could take advantage of this and use transarterial catheter therapy to deliver localized treatments to the liver tumors while really sparing the normal liver parenchyma that's really getting its blood supply from the vein. And you can often deliver medications to the liver tumors in a higher concentration than you could achieve if you gave them systemically. So, the main limitations I would say to liver-directed therapy are it's not a systemic therapy, right? We are just treating the liver most of the time. That's with a caveat, an asterisk that I'll talk about in a minute. And it's really based on institutional expertise. I always give this talk and I somewhat feel like an imposter because I'm not the one that actually does these procedures. Here at Jefferson, we have a team really of 3 dedicated interventional radiologists, Dr. Dave Eshelman, Karin Gonzalez, and Rob Adamo, who are the IR docs. They're specialized trained radiologists that do this procedure in all of our uveal melanoma patients. And not every institution, has that expertise. So who is a candidate for liver-directed therapy? Really, I would say anyone with hepatic dominant liver metastasis and appropriate liver function. So, appropriate liver function, really the bilirubin is something that we consider to be kind of a hard line for most liver-directed therapies. Bilirubin over 2, sometimes it's a little tricky. It can be unsafe to give liver-directed therapy. And so for some patients, liver-directed therapy in any form is a great first-line treatment because a lot of the treatments have kind of, when you look at other treatment options, a lot of liver-directed treatments have more of a minimal commitment, often kind of monthly. I would say for some of our standard of care options, things like radioembolization is kind of like a one and done. And patients are really able to maintain quality of life because there's few, if any, kind of in-between side effects. So it's not to say that these treatments don't have side effects, but kind of once you get through the treatment, a lot of patients are able to maintain the quality of life in between because they're not taking a pill daily or have some of the more kind of lingering or unpredictability of side effects from things like immunotherapy. And so when do we use it? Like I said, it can be used first line. Sometimes we use it up front if there's really bulky liver metastasis that we need to control, and then patients go on to a systemic therapy. Sometimes we save it kind of to rescue the liver if systemic therapy treatments are not controlling the liver. And sometimes we can use it in combination with systemic therapy. That's really only in the case of if someone's on systemic therapy that's not a clinical trial. You can't just sprinkle in liver-directed therapy if someone's on a clinical trial with another drug. And I would say generally it's a discussion where liver-directed therapy fits in. For any of you out there listening who, have been a patient here at Jefferson, it is a conversation. It is a discussion where we talk about, what's kind of maybe best medically and what makes the most sense logistically, where it fits in with other systemic therapies and trials and different things. So it is definitely not a one size fits all, definitely a discussion with your provider and team. So why do we think liver-directed therapy, if it's just treating the liver, can improve outcomes? This was a retrospective review of patients we did here at Jefferson, really just kind of globally looking at how did patients do when we gave them systemic therapy first versus how did patients do if we gave them liver-directed therapy first. Granted, the caveat here is when we talk about systemic therapies, we're talking like 70s, 80s, 90s, early 2000s. So certainly not with the systemic therapies that we have now, the most recently FDA approved Kimmtrak or other immunotherapies. But that said, it looked like patients who got liver-directed therapy first in kind of this more modern cohort really did better. And so here's just the survival curves looking at that. If you really look at cohort 2 and 3, their overall survival seemed to be significantly improved than those who got systemic therapy first. Obviously, this is all changing as we have more effective systemic therapies and hopefully more coming down the pike. But it is just a sign that if you can control the liver with liver-directed therapy, that can improve overall survival in patients. So what are the types of liver-directed therapy? Not all of these are offered everywhere, but I'll just mention kind of what we tend to offer and have here at Jefferson. So one of the standard of care treatments that we have here is something that's actually been kind of homegrown at Jefferson. Dr. Takami Sato and team now better part of 20 years ago, developed this treatment, something called immunoembolization. So it's a combination of cutting off the blood supply to the tumors, which would kind of, increase what we call tumor antigen, or really causing the tumor to die a little bit and kind of show itself to the immune system, in addition to giving a little bit of an immune boost with something called GM-CSF and IL-2. And on the right here, you can see this is kind of what the angiogram looks like. So this is what the interventional radiologists are actually looking at when they put the catheter in. Hopefully you can see my mouse. So this is actually the catheter going in. And this is the contrast that goes through. And you can see these kind of lighter gray balls at the end of this tree. And those are the tumors. So I would say kind of 1, 2. And then this is actually the patient 2 months later going in to treat. You can actually see that the tumor is basically almost gone. So this is just one instance of a patient who really had a great response to immunoembolization. We have looked back retrospectively. Again, this is a treatment that's been given since at least the early 2000s. It's not been in a kind of head-to-head against, other types of treatments necessarily, other than bland embolization, which was the one study. But the median OS was about 16.8 months, and the OS at 1 year is actually 70%, which is actually similar to some of the more recent systemic therapy trials. But what was really unique is that there was patients who really had an exceptional response living greater than 3 years. And so we actually found that in this cohort of patients, about 15% of patients had an exceptional response to IE, some of which who only needed IE for the larger part of their treatment course, or who only needed a handful of IEs and then actually had a decent treatment-free interval. And so you can see here in this median OS for group A, which are patients who are surviving greater than 3 years, their actually median was about 52 months. And here's just an example of a patient who, this is their MRI initially in 2010. This is the tumor, the kind of darker gray spot. And this is actually 2017. And all they were still getting in this time was intermittent IE. And you can actually see the tumor is actually a bit smaller. It's still there, and they had no other tumors develop. So this is one of our kind of exceptional responders to IE. So IE for us is a good first-line therapy. Or a therapy to follow systemic therapy. And like I said, it's very well tolerated. And for some patients, it's really the only treatment they need for a good portion of time. Another type of treatment is called radioembolization. This involves kind of the same procedure going in through the hepatic artery in the groin and delivering tiny radioactive beads to the tumor. So similar in some ways, you can actually think to the plaque radiation that some of you have had in your eye. So it's really focused delivery of radiation particles. There's been a number of experience published. We did a prospective trial here where we actually looked at patients who got IE, then radioembolization, or radioembolization, then IE. And you can see the data on the right. Both of the overall survivals were a bit similar. And you can see that, for partial response, this is when they got the RE. Radioembolization, was around 33 or 39. So about a third of patients actually had a partial response, no complete responses. And then a number of other patients had stable disease, more so having stable disease in group A, who were getting it first than group B, because you could say that the patients in group B actually had failed kind of their prior therapy. So, but overall survival ended up being about the same. So another type of treatment we offer is something called chemoembolization. And I would say that this has been historically reserved for patients with very dominant large liver tumors or greater than 50% of their liver involved. It can actually, for these patients who have rapidly progressing large tumors, really kind of pull patients, as we kind of say, back off the cliff. So there was a trial of 50 treatment-naive patients who showed up with really bulky tumor. And we had a disease control rate of about 72%. Unfortunately, still the 1-year overall survival is not as good as we would like, but it did kind of pull them back kind of off that cliff. And you could argue that if we had maybe a effective systemic therapy to kind of back this up initial control, we might have had a better overall response. And hopefully that's where we're headed. But with chemoembolization, we do have a clinical trial ongoing right now that we're actually enrolling patients with much more limited tumor as first line. And the data is not yet out there, but it does look like this treatment may also be very helpful in patients with actually more limited tumor. And then here on the right, you can just see an example, patient with large tumor, these kind of darker grays and the lighter gray. And then this was a subsequent scan at about 6 months later showing an improvement. So that's our chemoembolization with BCNU. There's another type of chemoembolization we can use with these kind of marinated beads in chemotherapy. The chemotherapy is doxorubicin. And we tend to use this for patients who have large, well-circumscribed tumors, so really kind of those ball-like tumors. Debdox can work actually very well for these patients. It's not so helpful in patients who have more of like an infiltrative pattern or more of like a miliary, a bunch of small little dots pattern. But you can see here in this patient who had a huge tumor, it's this big thing here, kind of with this kind of almost kind of firework shape vasculature in it now. And this is the angiogram, got Debdox, and you can see this is just 15 months later, the tumor is basically 1/3 the size. And actually this was another tumor down here that's also shrunk. So Debdox for these types of tumors can actually work very well. So another type of liver-directed treatment that I want to include is something called ablation. We tend to favor ablation over surgery just because in ablation, it's much less invasive. It's not a huge liver surgery, and it actually gets similar results because basically you're putting a needle into the tumor and burning it, and you actually burn kind of a margin to get a negative margin. We really reserve this for patients with either solitary or oligometastatic disease. So oligometastatic meaning really not more than probably 2 tumors. And we also use the rule, tend to use the rule, they have to be kind of greater than 3 years after primary diagnosis, because sometimes if tumors develop closer to that, it's really just, the tip of the iceberg, and other ones will develop. And we always say we don't want to just keep going ablating all these tumors because that can kind of leave the liver like Swiss cheese. RFA along with surgery for select patients, has been shown in the literature to be an effective strategy for these patients. And then we also tend to use this sometimes, not just initially, but in patients with what we call a rogue lesion. So say they're getting immunoembo or they're even on another systemic therapy, and there's really one kind of stubborn tumor or 2 stubborn tumors that are just not responding, but everything else is. Sometimes we'll go in and ablate those. And we did look at a handful of patients using this technique as more of a rogue lesion ablation approach. And we did improve it to a 2-year survival, about 76%. And median time to either an other liver or extrahepatic disease was 8 months. A lot of times it's not that these tumors will regrow, but other ones will, oftentimes outside. And here's just again an example on the right. This was June of 15, had this one tumor. You can see it's black on the top and then kind of white on diffusion, so meaning active. It got ablated. If you look at the top scan now on the right, it almost looks like the lesion's larger, but that's actually just the ablation cavity. It's all dead in there, because then if you look at diffusion, you no longer see that bright white dot. So this is a tumor effectively killed by ablation. So now I'll just pivot briefly to some liver-directed therapies that are in clinical trial, or actually the clinical trials have completed, and we're kind of waiting, for potential FDA approval. So one of those is the FOCUS trial, otherwise called PHP, or percutaneous hepatic perfusion. So for those of you who've never heard about this, it's a much more intense procedure. I meant to put up a schematic of kind of what the other, immunoembo, radioembo, chemoembo kind of look like. That's really just a catheter in the groin that goes right to the liver, and you can deliver medicine, and then your catheters come out. This one is a little more complicated in that there's an infusion catheter in one groin. The chemotherapy kind of goes in, it goes through the liver. It's then collected in the venous system when it's still in the liver. And then it's actually pulled outside of the body through a filtering system and then back in. Because the issue is that if you let this blood kind of go out to the whole body, the blood that has the chemotherapy, this melphalan is very, very strong and can really damage your bone marrow. So you basically perfuse the liver with high doses, but you capture the blood before it has a chance to kind of go to the rest of the body. So this was a trial that had been ongoing. We participated in it. And some of the data has been read out already. There's an expanded access program that is ongoing at various centers in the U.S. This is just a snapshot of some of the data. Initially, the trial was randomized to a best alternative care, but if you just look at the PHP arm, here an overall objective response rate of 31%, disease control of 65%, and this is what they call the intent to treat population, so a bit similar. And then we look at overall survival, median 19 months, and then in the intent to treat, about 20 months. So, a more involved treatment option, but certainly a liver-directed therapy that could be useful for some patients. There's another type of liver-directed therapy that's ongoing now in clinical trial that actually kind of bridges the liver-directed therapy and the systemic therapy world. So remember, I said caveat asterisk when I first said that these are really limited to just the liver. But there are some things that we can do in the liver that can actually control disease outside. Technically, immunoembolization, the first treatment that I discussed, when it was developed, there actually was a reduction in development of extrahepatic disease, possibly because of some of the immune system being woken up in the liver at the time of the procedure. This treatment, Perio or SD101 by Trisalis, is another kind of attempt at that. So this is actually not embolization, but it's rather infusion of something called SD101, which is a TLR9 agonist. It's an immune stimulant. You can read in the kind of the top arrows all the different things that a drug like this can do. And then it's actually being combined with systemic immunotherapy. So the original cohort was a single agent, just infusion. Then we're combining it with PD-1, and then cohort C will be a combination with PD-1 and CTLA-4. I didn't go into detail here. We all know that drugs like Yervoy and Opdivo, or the combination of, can be used in uveal melanoma. The response rates are not as great as we see in cutaneous. So this is an effort, if we kind of do almost the triple therapy, systemic plus this type of liver-directed therapy, we can kind of capitalize on the efficacy and improve results. And then lastly, I'll just mention the concept of intralesional therapy. So intralesional therapy isn't going through the artery in the groin, but really actually going through the outside and putting a needle directly into the tumor in the liver. So this is one approach that's been ongoing. This is slides courtesy from Sapna Patel at MD Anderson. They used a drug called PV10, which is a rose Bengal, and they actually inject it directly into the liver to kill liver tumors. You can see here they call a waterfall plot. So, a good portion of patients did actually have some shrinkage of tumor. And then here's just an example of a patient who had tumors injected and had what's called a complete metabolic response. So this is using CAT scan and PET, and you can see an improvement in this tumor, harder to see, and this tumor almost looks like it's gone there. So I briefly mentioned this before, kind of liver-directed therapy, maybe not for everyone. There are some limitations and considerations. For some patients, our best attempts at liver-directed therapy, tumors in the liver just don't respond. Some tumors have kind of a difficult arterial blood supply, so it's kind of hard to get to them. I think we're still trying to figure out if there's other resistance mechanisms for getting the drug to these liver tumors that could be helpful. Occasionally, anatomy issues exclude patients. So this comes up in radioembolization mostly. If there's little blood vessels that are leaving the liver that can be cut off, those patients are excluded from radioembolization because it's very unsafe if little tiny radioactive beads get outside the liver. Patients with a lot of extrahepatic disease, certainly symptomatic extrahepatic disease, liver-directed therapy may not be the best way to go. Ideally, we would have better tools to kind of predict who's going to be one of these great responders or who needs upfront systemic versus liver-directed. And then lastly, I can't stress, you really need kind of skilled and dedicated interventional radiologists to do this. And then I just wanted to just throw this up here. This is just a snapshot of some of the liver-directed therapy clinical trials that are ongoing right now. And with that, I will stop, share, and see if we can get back. I have to turn my camera back on. Oh, camera on.
Your camera's good. Can you hear me okay?
Is it on? Is my camera on?
Yes, camera's on.
Okay, great.
Wonderful. Okay. Well, give me just a sec. I'm going to actually mute your line just to make sure that I don't get a feedback. Okay, so that was really informative. And if it's okay, I'm going to ask you, can we get a copy of those slides to include as a link in the show notes? That way, anybody who needs to just kind of be able to go through and who wants to dive into the data, they can look at those. And then, of course, that last slide with the clinical trials that are liver-directed relevant, that would definitely be good to have. But I am seeing a good number of questions come in. So do you have a few minutes that we could run through? I think I have maybe 6 or 7 questions.
Shoot.
Okay. All right. Let's go for this. And if you just mute yourself anytime I'm talking, and then unmute yourself to talk. It'll make it easy. All right. So how long do you wait after doing a liver-directed therapy, or how long would you recommend you wait before determining if it's effective and moving on to something else?
So it a little bit depends on which liver-directed therapy. In general, I didn't go into too much detail about this, but let's take immunoembolization, for example. If someone comes with tumors in both lobes, we only treat one lobe at a time, and we tend to treat the lobes at 4-week intervals. So what happens is patient shows up, we decide that's the right treatment. They get, say, their right lobe, often their right lobe treated first. They come back 4 weeks later, get their left lobe treated, and then we repeat scans. And then it's really based on those scans that we determine the next step. Things like immunoembolization and chemoembolization can be a maintenance program, meaning it's not just you get one cycle and you're done. There's some patients who get IE, especially for years. And, I've had patients who've gone 3, 4, 5 years with just getting intermittent monthly immunoembolizations. Chemoembo, you probably can't go much more than, 6, 12, 15, though could be spread out over a period of time because there are patients who then run into blood count issues. It can drop your platelet count and your white blood cell count. So we have to tend to separate those. So, I think one good cycle, in a scan, if things are kind of equivocal, maybe there's a little bit of growth here, a little bit of shrinkage there, we may go again, but certainly if there's significant growth, then that's when you would kind of call it and move on to the next. With radioembolization, it's a little bit different because it's kind of a one and done. We tend to get a scan about 2 months after because there's a lot of inflammation early on, and then you make the determination where you go from there. For some of the clinical trials, it's kind of dependent.
Okay, that makes sense. Totally makes sense. Thank you. Okay, next question is, do you suggest doing multiple types of liver-directed therapies in a row? So for example, say doing chemoembolization and then changing to, well, let's just go back to the very beginning. Let's say they were able to do microwave ablation or radio ablation, and then after a period of time they had one or two more spots show up and it was still localized enough that liver-directed therapy might have been an option. Like, can you do multiple types of liver-directed therapies kind of in a row, depending on which they are, I guess, if that makes sense?
Yeah, you can. I mean, we tend to have kind of this, thing where you go, IE or RE followed by IE or RE followed by chemo embo is kind of our usual kind of thing. But like I said, we have the trial now with using chemo embo kind of more first line. So that might get turned on its head, but you can certainly sequence liver directed therapies. I wouldn't sequence them if there wasn't progression in between. You would only change if there's been progression. But the only limiting thing for sequencing multiple liver directed therapies is that at times there can be some arteriopathy that develops, meaning sometimes the arteries that are in the liver can sometimes get a little, we kind of just say beat up, especially if they've had a lot of embolization. So sometimes that can be something that prevents additional liver-directed therapies. The good news is that the liver and liver tumors like to make new blood vessels. So even if, someone starts to develop a bit of an arteriopathy, you kind of give them a break, and sometimes new blood vessels are formed that you can kind of then gain access to. But you could certainly go, ablation, other types of liver-directed therapy, and sequence those. The other thing is that with radioembolization, we do see sometimes in patients who've maybe had it years ago, sometimes there could be cirrhotic changes. So sometimes the liver can, because with radioembolization, you are kind of radiating, yes, the tumor, but there is some bystander effect. So there are some patients post radioembolization that will have some kind of changes in their liver that sometimes can make other liver-directed therapies maybe a little bit more of a challenge. But we certainly have patients who've gotten the whole gamut. You throw PHP in there. We've had patients who've gotten IE, RE, chemo, embo, and PHP. So it just depends on the health of the liver.
Okay, that makes sense. Okay, so this question is asking, with embolization, why not just leave the artery feeding the tumor blocked forever and suffocate it? Are the exact words.
So kind of two things there. One, like I mentioned, unfortunately, the tumor will get smart and develop a new blood supply. So even if you block one, it will make a new road. And we tend to think of, so permanent embolization is a thing. Actually, one, it's a separate treatment in and of itself called bland embolization, and radioembolization. They are permanent beads. Those little radioactive beads, they get in there and they block that artery. Same with DevDocs. The problem is, again, the tumor will potentially make new blood vessels. And two, if you are trying to deliver a medicine to them, so immunoembolization, you're trying to deliver GM-CSF and IL-2, chemoembo, you're trying to get BCNU to that tumor, then you actually need that artery as a road, as a lifeline. So IR will say, they need these vessels kind of open, to be able to get the medicine there, essentially. But there is kind of rationale though for blocking it kind of intensely, but you still maybe want to be able to get medicine to it if the tumor's still alive.
Okay, so you mentioned overall survival and just kind of showed some statistics there. Is overall survival, when it's listed in those kinds of that data, is it for that treatment alone, like overall survival from the time they start a treatment to when they are no longer able to continue that treatment? Or is it overall survival from time of diagnosis with METs to time of death?
I would say sometimes it kind of depends. But it's the only chart that showed actually overall survival from time of eye diagnosis was actually, I think, the one from our experience with liver-directed therapy, showing that there's not something called lead time bias that is dependent on when the eye was diagnosed. But most of the time it's like from kind of either enrollment kind of on the whatever treatment it is, or sometimes if we're looking more globally, from the time of metastatic disease.
Okay, wonderful.
Oh, hold on, didn't mean to do that.
It's okay. All right. So with this question says, does age correlate negatively with metastatic disease? Like, are you typically experiencing metastatic spread that's more aggressive if you're on the younger side?
And I don't know if we know that for sure. I mean, I think There's thought that risk of Mets goes up with age. So if we just look at primary eye diagnosis, there is some thought that older folks may have a higher risk of recurrence. When it comes to how they fare in the metastatic setting, I don't know if anyone's ever kind of looked at that kind of globally. I think some of what we run into is, the older you are, the more potential comorbidities you have, and sometimes the less robust you are to be able to get some of the more aggressive treatments, I'll just say. And so if there's other comorbidities such as heart disease or bad diabetes or something like that, that then prevents you from getting, and this isn't just liver-directed therapy, but goes for all of our systemic therapies, then obviously that could not be, that could be a negative effect. But I mean, I think in general, with all cancer and all treatments, age is normally on your side if you're younger, because you're typically healthy otherwise. But I don't think age alone necessarily changes outcome.
Okay, that makes sense. So this one is asking about miliary spread, and I'm actually not sure I know that word, but it says, do liver-directed therapies treat miliary spread or mainly just bulky tumors? So I guess, can you define miliary spread for us first?
So miliary refers to really very teeny, tiny, small tumors. So, unfortunately, the way that uveal melanoma is actually staged, we don't talk a lot about stage in uveal melanoma, but when patients are metastatic, it's actually broken down by what's called M1A, B, and C. And this has to do with size of largest tumor. So M1A is 0 to 3 centimeters, M1B is 3 to 8 centimeters, and M1C is greater than N centimeters for the largest tumor. So you saw a couple of MRIs where you saw tumors this big and then tumors this big. That probably doesn't even tell the whole story. For folks who come here, we often talk about percent liver involvement. And that's probably even more important than largest tumor size, because in miliary disease, you could have 80% of your liver involved by, 1 centimeter and smaller tumors, and that can be concerning. And that sometimes is more difficult to treat than somebody with, 1 5 centimeter tumor, because it has to do with the amount of healthy liver there is. And miliary disease, when it comes to liver-directed therapy, I would say things like DebDox, that beads treatment that I mentioned, probably not the one that we would reach for, but certainly patients with miliary disease can respond to chemoembo. We've treated, I didn't show an example, but we've treated a lot of patients with miliary disease with chemoembo, with BCNU, with some positive results. Miliary disease too is hard to find on a CAT scan. So it's one of the reasons, why, a CAT scan will show an 8 centimeter tumor, but will it show these really teeny tiny dots? Sometimes you only see those on a good MRI. So it's one of the other plugs for getting surveillance with an MRI.
Gotcha. Okay. That totally makes sense. And I feel like that's really helpful information. So just for, I guess, our final question, maybe, do we have time for 1 or 2 more questions? Okay. So this question is, when is it estimated that Jefferson will be able to offer the PHP for patient treatment?
I'm not sure yet. So
to
there
be
is
determined.
To be determined. We'll leave it at that. I mean, it is a treatment that I hope that we'll be able to offer. Right now, there are a number of institutions around the country. I know, obviously, Moffitt has the most experience with it and is offering it now. Hopefully, we will be able to offer it here.
Okay, and then this one is asking if, and I think this is kind of just a plug for just genetic testing, and I know we have a lot of genetic testing through Castle that's done, but is there any additional evidence showing, or how do I say this? It says, does additional genetic testing now offered through Castle? So say someone has extra sample of their tumor from original time of diagnosis. Does that additional testing that they now offer for that extra sample, does that provide any value, I guess, for someone who's in the surveillance period and they don't have metastatic disease, but they have that opportunity? Would you say that that's valuable information to have?
I guess just kind of taking it back to liver-directed therapy, not in regards to, predicting who's going to respond to liver-directed therapy. And I guess when you talk about the extra testing for Castle, they're offering like GNAQ, GNA11, SF3B1 status? Is that what the person is?
Yeah, so I think that it's that, 5-6 years ago when they were diagnosed, some of those GNAQ sequencing were not offered in the Castle test. And so now Castle has come back and said, if you have extra tissue and you want it tested for these specific markers, we can do that if you choose.
Gotcha.
That's what they told us earlier this year, I think, at some point.
Yeah, I would say I don't see it changing management necessarily right now. There is a mutation that if we see it in the primary tumor, it may suggest a better kind of outcome. But I imagine it's going to track maybe a little bit with the initial kind of class 1, class 2. So I don't know if it would change surveillance. And certainly if it's many years out now, you may have gotten over that 2, 3, 4, 5 year hump. So I don't know what how that information would be helpful now. But things like SF3B1, which is a mutation that we think predicts kind of better outcomes, or certainly in the metastatic setting, patients tend to maybe do better. And if they recur, they might recur a little later. Things like IFAX, or as we call it, but it stands for something a little bit different. Those patients have a lower risk of recurrence, whereas obviously things like BAP1 have a higher risk of recurrence when it's in the eye. And then GNAQ, GNA11, it's kind of more of just the initial driver mutation. It doesn't necessarily change prognosis that we know of for sure. There are some clues here and there. And anyone who wants to know more about genetic profiling of tumor and how it may impact treatment, we put out a publication probably about 9 months ago. And I think also available online is my ASCO presentation from 2020, I think, on the mutational landscape of uveal melanoma. And I go into all of those mutations in great detail.
Okay, wonderful. And I apologize. I thought I was muted as I was trying to type down the name of that presentation. So if you heard the in the background,
I can send you the link to it to you guys.
Okay, perfect. Yeah, that would be great. So, Dr. Orloff, this has been amazing, and we are so grateful for your time and your expertise. I feel like I'm one of those people that, as a patient myself, I find it incredibly valuable to have someone in the physician field that I'm working with or that I'm talking to who is very knowledgeable, but just also confident in what they're doing. So thank you for being one of those people and for volunteering your time today for a little bit. We're going to go ahead and let you go back to the rest of your day in the future meetings. But thank you guys, everyone who was here live. And thank you again to Dr. Orloff.
All right. Thank you.